the second time with, okay, it starts now again. Hi, I'm Shema. Today I'm facilitating together with the great Rabi Jiham. It's my second time. I'm still so excited, and yeah, I'm so happy for the whole crowd being here, and I always know that I can count on you if I don't know anything. Yeah.
Emma, you're getting a special treat because so many people are turning their video on, and I think it's all because they want to encourage you on your second round of facilitation. It's hard not to acknowledge everyone. So thank you, Ariel, Hans, Drew, Yasmin, Subangi, and Amr. What's really cool is that sometimes when saying hello to you all, people who've turned their video on, I have to scroll over your name because I haven't met you. But this is the first time I can do it blind, which is really, really cool and a testament to how often you all are hanging out in VMR. And a special congratulations to Drew for I saw your post on Twitter from PGY1 to PGY2. Congrats. How does it feel?
Well, let's just say that I still have about 6 more months of feeling like an intern because as a med peds, they smashed 2 intern years together.
Right.
So I still have like 2 more blocks where I'm basically the most senior intern in the room, but
Gotcha. No, well, hey, you still get to update your Twitter handle, which isn't everything, but it's certainly a moment to hold and celebrate with your VMR fam. So do any of you have a case that you want to share with Shema and I today? It really, the spectrum can be from, Drew, you do? Okay. All right. Oh, that's so exciting. What an honor on this momentous occasion.
Yep, last day of the year, the only day that I have off this week, and a case that hopefully will be in the spirit of 30-minute VMR because it's a devastating consequence of a really common diagnosis and a no-miss diagnosis.
Awesome. All righty, we're ready to rock and roll. I can't wait to learn from Shema and you all.
Let me just make sure that the whiteboard is ready. And it is, good. All right, so chief concern for this patient is headache and altered mental status.
Okay, I have to say, altered mental status is my favorite chief concern. As I go through it, we have the famous MIST schema. So if we have any metabolic issue, like something with the liver, hepatic encephalopathy, then thinking of infection. And the most common, the important thing is who is the host? If it's an older person, thinking of something like a urinary tract infection or pneumonia. And then also thinking of some structural issues, something like a subdural hemorrhage and also toxins or any kind of withdrawal. And also thinking of headache, what we always learned is it a primary headache or a secondary? So do we have any signs of systemic symptoms like fever that concerns us for a secondary issue? And as we know, for the primary ones, we wouldn't see any objective finding now, like, so we would think of the typical ones like migraine, cluster, and tension headache. But the most common thing for me is to exclude any systemic symptom. Yeah. Mike to Rabi.
That's so crisp and so perfectly said, so much in such few words, and I have nothing to add to that. And I would just say, to summarize briefly, when you have altered mental status, it's no different than approaching kidney injury, which is it the actual kidney involved, or is it a systemic disease affecting the kidney? And in most patients, it's actually systemic disease like hyponatremia or hypoglycemia or a systemic infection. And so the key question is, what does a headache do to that analysis? And the headache, of course, it prioritizes an intracranial cause. But the problem is that headache is so also not unheard of to be part of a systemic disease. Many people with pneumonia get headaches. So the headache moves the needle closer towards an intrinsic cause, but it doesn't confirm it. As a fun fact, even focal neurological features don't confirm an intracranial disease process. There are some systemic diseases that disproportionately affect one side of the brain. And the best example is hypoglycemic focal seizures. Patients can get hypoglycemia and have a focal seizure because some parts of the brain are more vulnerable to hypoglycemia than others. So there's really nothing that you can do that will definitively tell you have a brain problem, even focal neurologic signs, let alone a headache. But what is really important, Shema, is something for you to reflect on in front of us, which is, how confused do you think a patient is if they can tell you they have a headache? Think about that for a moment.
Not that confused, because I remember, like, if we think of something like an encephalitis, we would have some cognitive deficits. So I wouldn't be concerned of that in this case.
I completely agree. I think the fact, if assuming the patient is relaying this information as opposed to somebody else, the fact that they can continue to endorse a headache is giving us some insight into the severity of the encephalopathy. But that comes with many, many assumptions, right? It comes with the fact that the patient is still telling us as opposed to somebody else. But the fact that they can utter those words is really, really informative. All righty, Drew, back to you.
About that. So this is a 65-year-old gentleman who actually arrives via EMS. And it's EMS who is giving this history, not him. He was at home with his wife the day prior to admission. And to his wife, he was saying that he had severe ear pain as well as a headache. He apparently was using a heating pad on his ear and was taking Tylenol. And then in the early hours of the morning of the day of admission, the patient then began vomiting profusely. And as his wife was trying to clean him up, she noticed that the patient had stopped responding to her. EMS was called, the patient was brought to the hospital. And when the patient was brought in, he had unequal pupils and his Glasgow coma score was 8. So as soon as he got to the emergency room, he was intubated. I'll go into the southwest corner just to make everything a little bit faster, because again, this is 30-minute VMR. Past history was notable for eustachian tube dysfunction and a bout of COVID-19 pneumonia back in November of 2021. And of note, this patient has minimal contact with the medical community until he was diagnosed with his COVID pneumonia. He's not had any surgeries. Medications, he's on Flonase, Tylenol, albuterol, and a cough suppressant. In terms of his family history, his father had asthma and diabetes, and his mother had osteoporosis. In terms of his social history, he lives at home with his wife. Although his daughter is also involved in a lot of his legal decisions. In terms of health-related behaviors, actually scratch that, one more thing about his social history. He works at a homeless shelter. And this case occurred in the Midwest United States. In terms of his health-related behaviors, he has a 25-pack year smoking history. And he also uses freebase cocaine, but that use has been in remission for the past 4 years.
Oh, such an intriguing history, Drew. Thank you. I know there's a your free-base cocaine. Thank you. So otherwise known as crack cocaine. Actually, Drew, can you enlighten us? Is crack cocaine falling out of favor, or you seem to have used those terms deliberately? Tell us more.
So the term crack cocaine came out of the cocaine epidemic back in the 80s, and it's associated with it's a very stigmatizing term to use, especially considering that use is associated with Black folk. So, and essentially what crack cocaine is cocaine that has been made freebase, not the cocaine salts that are used for
Gotcha.
that are used by more expensive folk. So that's why I use the term and I don't use the term crack.
Gotcha. That's very helpful. Thank you. I didn't know any of that. That's really, really helpful. No, thank you. Shema.
Okay, I have to say we get so many information. Seeing that he also had some ear pain makes me wondering, might there be some infection or something like an otitis media? And if we think of otitis media, can have several complications as something like a mastoiditis. It can cause an abscess. So I'm still thinking of an infection, also thinking of the age of the patient. Another thing that also makes me concerned, I don't really know about his use of Tylenol. As we already know, for Tylenol, liver, might there be something with the liver causing something like a hepatic encephalopathy, and also something like an acute liver injury. And then he was also vomiting. And the thing of vomiting is it related to something like an increase in intracranial pressure, or is it rather something like an increased reaction of the parasympathetic system? And another thing that makes me concerned is seeing that his GCS is 8. And as we learned, if we have a GCS of 8, we treat before we diagnose. So yeah, as it was already here. And then seeing that he also had some COVID makes me also wondering about some hypercoagulable states. So maybe something like a sinus venous thrombosis, maybe something like this. And another thing that makes me concerned, yes, he has a 25 pack years smoking history. Maybe he could also have some kind of malignancy, which also could predispose him for something like a thrombosis. Yeah, these are the first things that come into my mind.
Yeah, that's absolutely superb. And Shema, you're really in keeping with what the 30-minute VMR format is for. It's not so much for nerding out about the background history. It's saying, what would you do next? And here you have a patient with a blown pupil who their next step is you need to understand what their intracranial anatomy is with the CT scan. Like that's basically the next step. And only then can you start to speculate on what is going on. So this patient comes in, gets intubated, goes right to the CT scanner, initially without contrast, to see if there's blood or anything there. And the question is, the question in terms of solving the problem, I think, is just to make sure that you don't make any assumptions. And I think we are set up to make 2 possibly false assumptions. The first is that the patient actually has eustachian tube dysfunction as a primary disorder. That's very unusual in older adults, though it's possible. And especially when there's upper airway disease causes like cocaine causing nasal destruction or sinus destruction, causing secondary eustachian tube dysfunction, you want to make sure that you're not dealing with something that is actually a specific lesion in that area. So let's not make that assumption. And 2, we're also set up to make the assumption that he began feeling sick when his ear was the problem. We have no idea when he was last well. And that could open up the door and change the time course of the disease process to well before his ear started to bother him. So he's going right to the scanner, and let's not make any assumptions about his eustachian tube and about when he started to feel unwell, because that will leave us less vulnerable to making some diagnostic mistakes. All right, Drew, back to you.
All right. On to the physical exam. And I guess since everyone wants the CT without contrast, I will give that to you as like the initial workup. So vitals, temperature of, let me make sure that I have this right, 39.5. heart rate of 104, blood pressure of 123/90. Actually, scratch that. Blood pressure of 60/44. Resp rate of 26. And he is intubated. So I don't remember what were his settings. He was setting 100% on 100% FiO2 with a rate of 24, a tidal volume of 500, and a PEEP of 5. On his exam, he's intubated and sedated. His pupils were approximately 7 millimeters in diameter and fixed. He was normocephalic. His left tympanic membrane was retracted and erythematous with exudates and blood in the external auditory canal. His neck exam was normal. Cardiovascular wise, normal, except for tachycardia. Respiratory wise, normal. GI wise, normal. Neuro wise, he was intubated and sedated, so you cannot get a neurological exam on him. And then extremities wise, normal. For his CT head, no acute intracranial abnormality. This is without contrast. But there was near complete opacification of the left mastoid air cells with fluid surrounding bones of the middle ear.
So, shall I start?
Yeah, I'll leave it there for now.
Okay, so first of all, seeing the vitals, as we know, there's this Q-SOFA score that we use to see whether we have a suspicion for infection. And as we can see, we have a systolic blood pressure below 90. We have tachypnea, and we have a low GCS. So we can say this person has with a very high probability something like a sepsis or an infection. So I would say that the headache itself is a secondary headache. And also seeing the heat exam, we have the retracted membrane and the exudates, which makes me now concerned of the otitis media, and also seeing the CT with the opacification of the left mastoid. So makes me concerned that we had an otitis media, which has led to a mastoiditis. Yeah, this would be my initial thought.
Yeah, no, I completely agree with you, Shema. I think that the CT is whoppingly positive, and it's hard not to make a lot of inferences on that. And I think the key question is it positive enough? Meaning that this patient has obtundation, intubation, and blown pupils, and the CT does not show anything in the brain. So how are you reconciling that discrepancy with like the CT being equivocal, but him being so comatose and having those pupils? How does that make sense to you?
Wow, I have to say I have no other ask. I mean, like the thing with the pupils itself, like pupils of 7 millimeter seems to, I mean, the size doesn't really concern me. The only thing that concerns me is that they are not reactive. So I would still think that there might be something within the brainstem or something like an increased intracranial pressure, but the CT didn't show any of it. But I have to say, Rabi, I don't know.
Yeah, no, I don't think anybody can know. I think that's superb that you're reaching that conclusion. It's very hard to. I think that the people should constrict in response to light unless he's given a paralytic, which he might have gone in the setting of intubation. So that might be the way you're misleaded. But I think CT, as you alluded to, is notoriously insensitive to detect many pathologies, but especially brainstem disease. So if you have bilateral and dilated pupils, you might worry about upper brainstem pathology. And here, in the context of infection, it might represent rhombencephalitis or inflammation of the brainstem, or it might represent meningoencephalitis with compression on the cranial nerves, or a vasculitic infarction. So I think the long and short here is the CTE offers us a clue, but doesn't fully explain the intracranial picture. And so I think you have to get more data, and that more data is probably going to be with an MRI. And I think it's amazing as a testament to the people providing the history for this patient, because how many people would look into an ear in a patient who was confused? Just think about that. If you didn't know that he had ear pain, would you have looked in his ear? And I'll answer that for me, probably not. So it goes to show you how humbling this process is, but also how imaging can bail you out. Because if you didn't look at his ear before the CT, you'll definitely look at it afterwards. Shima, what do you think about treating right now? So if you're there treating him, what might you do in the RX category, which we don't have celebrate here much on this podcast, but maybe we can practice sometimes.
So the basic thing that I would do, if we excluded an intracranial pressure and seeing this, basically what I do is first take some blood cultures.
Beautiful.
And then I would give some empiric antibiosis. And if I suspect something within the cerebrospinal fluid also, I would also take some CSF. And yeah, this would be my basic approach.
I completely agree with you. That's exactly what you should do. One nuance to reflect on is if you give this patient empiric treatment for meningitis, which is vancomycin, ceftriaxone, ampicillin, and acyclovir, you might miss something really important here. And what we should think about as common causes of aggressive mastoiditis is Pseudomonas. And none of those antibiotics cover Pseudomonas. So here you may have to get a little creative about how you treat this patient, covering both meningitis, but also considering covering Pseudomonas with an anti-Pseudomonal agent. So here there's a lot of management reasoning about how to actually give the patient treatment. Yeah, so piptazo or carbapenem, as you just said in the chat, would be something you'd think about. All right, and yes, Hans added cefepime. Superb. All right, Drew, tell us more, please.
So good thing we actually got an LP before. I think we got the LP before those antibiotics were given, or at least before or at least like within the hour that the antibiotics were started. There's a whole bunch more imaging. I think the main thing that people wanted was an MRI, but I'll go to labs first. So CBC, white count of 28.2. With 80% neutrophils. Hemoglobin of 15.2. Platelet count of 252. They got a CMP, sodium of 140, potassium of 3.8, chloride of 106, CO2 of 18, BUN of 15, creatinine 1.2, glucose of 192, the initial glucose was 181. So for those of you who are saying rule out hypoglycemia, no, he was not hypoglycemic. Calcium of 9.3. They did not get a magnesium and phosphorus on admission. His AST of 22, ALT of 25, ALK Phos of 81, total bili of 1.6, although it was not fractionated, and albumin of 4. And then the MRI that they got showed inflammation of the leptomeninges, no abscess or any extraaxial collection, ventriculitis, small acute infarcts within both cerebral hemispheres, and suspected left mastoiditis / otitis media and suspected dural venous thrombosis involving the left sigmoid and transverse venous sinuses without occlusion. But now for the money shot. There was an LP that was done. And the fluid that came out was cloudy. 160 red blood cells, 1,425 white blood cells, with 98% neutrophils. Protein of 480, glucose of less than 5. They ultimately cultured and also did PCR on the cerebrospinal fluid, and they also got blood cultures as well. And the results of those will reveal the final diagnosis.
Okay, so I have to say, now seeing the lab, so we have a leukocytosis, also seeing the high blood sugar. And what Robbie actually mentioned was Pseudomonas, as I remember that Pseudomonas is the bug that you always have to keep, have to be concerned of, like, because Pseudomonas causes, especially in older people that don't have their sugar under very good control, something like an otitis externa maligna. And I think that this could have also led to an otitis media, and then the complication of the mastoiditis. And also, as we know, other complications can also be sinus venous thrombosis, and also then something like a meningitis. As we can see, we have inflammation of the leptomeninges, and also seeing the cloudy cerebrospinal fluid. So basically, the pattern is whole. I'm concerned of a bacterial infection, because we have low glucose, we have elevated protein, and we have a high amount of cells. And this is basically the pattern that I expect in the bacterial infection. I'm still not excluding fungal infections, because this person, because people with elevated glucose, I would think of something like diabetes, seem to be immunosuppressed, immunocompromised. So I would still not exclude infection, but seeing the cloudy fluid still makes me really concerned of a bacterial infection. Yeah. What do you say, Robbie?
Shema, that was absolutely superb. That is such a brilliant analysis of a very advanced topic. And I think it is really a testament to you that we're able to go back and forth and ask each other hard questions about this case and what to do. And I think the fact that you were able to articulate with such clarity what's going on here, including naming the specific bug and why. It's really, really admirable, and I think very inspiring to see, quite honestly. Yeah, I think, I'll just share just a couple of pearls. One thing is you have to be careful when you interpret the MRI. The most common cause of leptomeningeal enhancement in many contexts is that the patient recently received an LP. So remember, the LP will make up the leptomeninges because you've just poked the leptomeninges from down below. But of course, that is ruled out by the fact that there's inflammation in the LP. And just for completeness sake, the differential diagnosis of a neutrophilic leukocytosis is actually every infection, viral infections, fungal infections, bacterial infections, because early viral infections can cause neutrophilia. But the differential diagnosis of marked over 1,000 neutrophilic leukocytosis is usually bacterial, but can be fungal. So I think here the real tension is this mucor, with that being much less likely than it being Pseudomonas. So just to talk at another sort of like more complicated analysis, which is to say, well, what do we make of the infarcts? The dural venous thrombosis is simple. There's local inflammation there causing local hypercoagulability, and that's easy to answer. But what do we make of the fact that this patient has subacute infarcts between the both cerebral hemispheres? Now that should influence your thinking a little bit, because mucormycosis is an angioinvasive fungus. It loves to go in vessels. So the key question is, does that reprioritize the probability here and push us again towards a fungus that loves blood vessels? And the answer is no. It should make you think about it, but you have a very easy explanation for why he has infarcts. So meningitis is inflammation of the meninges, which coat the cranial nerves and coat the blood vessels. So it's not uncommon for patients with bacterial meningitis to get hearing loss as a result of losing and coating cranial nerve 3, vision loss, chronic headaches, hydrocephalus from obstruction of the arachnoid granules, masses in the brain like a cryptococoma or tuberculoma, but also actually infectious vasculitis. So the inflammation in the meninges blocks the blood vessels and causes strokes. So here, everything collapses down to the meningitis. And so I would be most worried about Pseudomonas, but common things being common. Could this be strep pneumo? Yes, strep pneumo loves the ear. It is a very common cause of otitis media. So I think the tension is it the base rate, strep pneumo being the leading cause? Is this a gram-negative rod associated with diabetes, which would be Pseudomonas and Klebsiella? And the specific kind of Klebsiella we'd entertain here is the hypermucoviscous Klebsiella. So, and here mucor would sneak in, but it's way too acute to be the lead consideration. So as is always the case in medicine, will the base rate win, and will it be strep pneumoniae again? Or will it be Pseudomonas rearing its ugly head? And the truth is, it doesn't matter. You need to empirically treat the patient for both unless you have culture data rapidly available. Any thoughts or anything you'd want to add, Shema, now that you've had some time to reflect and think instead of the rapid response that you had to do?
I have to say, this was pure poetry listening to you, and I really don't have anything to add. I'm just very excited for the final DX because I know it will be so educating, and thank you, Drew, for this amazing case. I'm so excited to hear the final solution.
Yeah, so you guys got it in one. I told you that this was going to be a case of a common thing leading to a acute emergency. And this is strep pneumomeningitis. The blood cultures and the CSF confirmed it. It was the only organism that was there. So he was, so this man was ultimately, was initially started on vancomycin, ceftriaxone, ampicillin, acyclovir, and dexamethasone, actually. But then he was ultimately able to be narrowed to ceftriaxone. They actually had put in a tympanostomy tube due to concern for mastoiditis. And because of his dural venous sinus thromboses, he was put on a heparin drip. And then he was initially narrowed to Pen G, but there wasn't much improvement. So he was switched back to ceftriaxone and metronidazole for better coverage. And he ultimately was discharged to a long-term rehab hospital after waking up and beginning to follow commands. So even though it was an emergent, oh crap, is this guy gonna die? He ultimately lived through it.
Drew, this is superb. I'm really curious to see what Seamus' thoughts are before we move on.
I have to say, I'm just so amazed by this case, and also seeing, as you said, common things being common. And I think that this is just an educating case for all of us, just if we are working in the emergency department. So I will really keep that really close into my brain now to think of it, because I'm like, as we always go through the bugs that usually cause a meningitis, I'm now like, oh my God, wait, didn't I think of the most common bugs of meningitis? So I will now remember it. Thank you so much, Drew. Such an educating case. And thank you to the whole crowd here on the chat. I really loved it with all of you. Thank you.
You know, folks, I hope you're seeing that, you know, Shema is in her late medical school years and is here publicly discussing a case no different than I think you can hear an attending do it. I mean, think about the conferences and reports and what you've been to. I don't think you'd be able to tell the difference between her and somebody who's completed their training. And I think it's a testament to the hard work that you're putting in, Shema. And I think it's kind of scary, to be honest with you, the fact that this is only your second discussion, to think of what you'll be like when, like me, you've maybe had over 1,000 under your belt. You'll put all of us to shame, which will be a delight to see when that day comes. And I think you're right. The biggest lesson to take away from this case is to learn all the pearls that are specific, you know, about what causes meningitis and how to interpret an LP, how to approach altered mental status and a headache. But I think the big theme in this case is whenever you're discussing a problem, always think, what do the last 100 people have? And then use specific data. So if you're trying to be rigorous, you'd say, the most common causes of bacterial meningitis are A, B, C, D, and E. However, I will also add to that list Pseudomonas because the patient has diabetes and has otitis media, as opposed to our tendency always, which is just to like go to the thing that's a special edition. It's most important when people have HIV related disease. The most common cause of HIV pneumonia is not PJP, it's strep pneumo again. So always, whenever you're thinking of what's going on with my patient, ask first, what is the base rate? And that will always win, always. But then don't ignore the fact that your patient may have some unique features about their case that differentiates them from the last 100 people. Here, diabetes and otitis media. So in addition, instead of replacing strep pneumo with Pseudomonas, you have to add them both. And who knows what he would have had, but yeah, the base rate always wins. And I'm glad that Drew taught us that lesson. And just to be honest, I thought it was going to be Pseudomonas. And so I'm learning this lesson myself too. All right. Thank you, Drew. We really appreciate you. And so glad that you were able to get this patient a rapid LP, rapid effective treatment, and give him the best chance of the recovery that he is having. All right, Promise, take us home.
Hi, everyone. This is an amazing case, Drew, and I feel like this is speaking to me because I'm starting my neuro rotation next week, and this is literally going to help me so much. And so we basically started with a 65-year-old male arriving to the emergency department with headache and altered mental status, and we see that he has his pupils were unequal and he is severely comatose. And then we also found out that he has a history of eustachian tube dysfunction, and we found that his vitals were very unstable. And so with someone presenting with altered mental status, I love the mnemonic that Shema gave us, which is MIST. So we want to start really broad and think about the metabolic causes, the infectious causes, the structural, and the toxins. And Robbie talked about it's important to consider how severe the mental status change actually is. And then when it comes to headache, we want to kind of break down into either a primary cause or a secondary cause. And so for primary, it would just be a migraine, cluster headache, or tension headache. And then with secondary causes, we have to look out for signs of systemic symptoms like fever or like pneumonia or like hypoglycemia or even malignancy. And then when it comes to the ear pain, we talked a lot about thinking about an infection like an otitis media, an abscess, and we also wanted to consider the vomiting that we see in this patient, whether or not it is because of increased intracranial pressure, maybe like hypertension, uncontrolled hypertension, or increased parasympathetic nervous system activity. And Shayma also made a great point about how this is something that I would take with me starting next week, that if someone has such a severe coma, then we would definitely want to treat before diagnosing it. And because this patient has a history of cocaine use, we talked about how it could lead to increased risk of thrombosis, and also it could trigger a stroke as well. And then when we saw the CT without contrast, we pretty much were thinking about a otitis media that leads to mastoiditis. But Robbie also said that for this case here, the CT is not good enough for detecting a brainstem disease, especially because in this patient, we see that they have an unequal pupils. So that's something that we can't quite reconcile with, and we would need to get an MRI and lumbar puncture and just more labs and imagings to work through this diagnosis. And then when we saw the lumbar puncture, we pretty much were thinking between a bacterial or a fungal infection because of the elevated neutrophils and proteins and the low glucose. And we talked a lot about the bugs, so we were thinking either Pseudomonas because of this patient having a poorly controlled hyperglycemic glucose, and then we also thought about Klebsiella or strep. And then for fungal, we were mainly thinking about mucor infection, and we found that this patient has a bacterial meningitis, which Robbie explained that it's because it's inflammation of the leptomeninges, which basically covers the cranial nerve, so it's not uncommon that we would see some cranial nerve signs and symptoms with that. And also because it could have infectious vasculitis because the meninges inflammation would block the blood vessels. And I think the biggest takeaway for me in this case is definitely the common things come first, and that is something that I would definitely remember when I go into my rotation next week. Thank you so much for everyone's participation and discussion. I learned so much from you all.
And we from you. That was a great recap. Thank you so much, Promise, and welcome back to the VMR World Status Plus Step 1, and we're excited to have you around. All right, have a great day, folks. So we're really looking forward to tomorrow. It is a promised to be a very unique and rare case by our beloved Andrew Sanchez, who is finishing up his intern year. Actually finished his intern year at Yale, and has a doozy of a case for us for RLR. So hope to see you then. Bye.
Bye.